Hello, everyone. My name is Hildegard Greinix. I'm a transplant physician working at the Medical University of Vienna in Austria. I've been working in the field of allogeneic stem cell transplantation and other cellular therapies for quite some time. And my research is also focused on graft-versus-host disease. When we speak about treatment of patients with chronic graft-versus-host disease and how we decide which therapy is suggested to a given patient sitting in front of, for example, me, then I think it's important to consider that chronic graft-versus-host disease is a very heterogeneous disease. That means patients have different manifestations with different severities, have different symptoms, have various lengths of duration of symptoms. So what is affected by chronic GvHD very frequently is the skin in the vast majority of patients. Over 50% also can have involvement of the oral mucosa. Around 50% can have involvement of eyes or liver. And fortunately, to a lesser extent, we see involvement of gut or lung. So when a patient comes in and we diagnose chronic graft-versus-host disease, and we do have internationally accepted criteria for that, then the first treatment that we suggest to a given patient sitting in front of us is always steroids. Because since the 80s, one can say, steroids have always been used as first treatment of chronic graft-versus-host disease. And usually the dose is 1 milligram per kilogram body weight. And as soon as we see that patients respond, we then taper the dose. And if patients continue to improve, we try to get them rid of steroids. Unfortunately, when we think about long-term effect of steroids, only about 20% of patients after 1 year after diagnosis of chronic GvHD are off steroids and off other medications. So a lot of patients need additional treatment. And in Europe, this additional treatment is ruxolitinib. This is the only therapy that has been approved by the EMA. In the US, beyond second-line treatment, also belumosudil, ibrutinib, and axatilimab have been approved, but this is not the case in Europe. So if a patient comes in and did not respond well to steroids, or when we try to taper steroids, and then this patient has renewed activity of chronic GvHD, we have to discuss other treatment options. And these other treatment options depend then on the organ manifestations, the shape and the condition of a given patient, other results, for example, blood counts, or whether a patient had or still has infectious complications. So, for example, ruxolitinib is difficult to be used in a patient when he or she has low blood counts, or also when a patient, for example, has a severe infection, like a fungal infection. And in that case, ruxolitinib could not be the best option. So, for example, at our center, we would then suggest extracorporeal photopheresis to this patient. This is a treatment called ECP for short, where the patient comes in, receives a venous access, and then the whole blood volume is filtered to a sort of cell separator. And in the device, the blood cells, the white blood cells are collected and are then exposed to a photosensitizer that is called 8-methoxysorolene. and are then UVA irradiated and then infused back to the patient. With this sort of treatment, patients have excellent responses when they have, for example, skin involvement, but also oral mucosa, eye involvement, liver involvement. ECP has to be given twice a week, and then in chronic GvHD patients, we administer it at the beginning every 2 weeks. And when a patient responds, then we continue every 4 weeks, and then try to taper steroids in the meantime. When patients receive ruxolitinib, this is an oral treatment. The dose is 10 milligram given in the morning and in the evening. And during treatment, patients have to come in to have their physical condition checked, but also their blood counts, or whether they have any infection. And they also need protection against infectious complications. If a patient, for example, has deep sclerosis of the skin as a manifestation of chronic graft-versus-host disease, that can also involve then the joints, so that they have a hard time walking or using their shoulders or arms, then we can decide together with the patient to either start with ruxolitinib or to start with extracorporeal photopheresis that works very well even in deep sclerosis. But patients have to know that the treatment takes time. So usually they have to wait for 9 to 12 months before they can see a better response with more softening of the skin. But interestingly, once we start ECP, a lot of patients come in and after a couple of weeks let us know they feel better from the skin status, they can slightly move better, and things like that. There is currently in Europe a trial starting where fortunately also our center can participate under the leadership of Robert Zeiser in Freiburg, where we will combine ECP and ruxolitinib in chronic graft-versus-host disease patients who are steroid refractory, to see whether we can get better responses in a shorter period of time with the combination of these two effective treatment options. If a patient, for example, unfortunately has lung involvement that is called bronchiolitis obliterans syndrome, in that case, it is quite challenging to find an efficient treatment because we know from prospective randomized studies that in this situation, ruxolitinib doesn't work that well. So the responses achieved after 6 months of treatment were below 10%. In another prospective study that was recently published, where ruxolitinib was also given to patients with lung involvement, they responded better when they had mild lung involvement. In that case, around 40% responded. If they had more severe disease, the responses dropped. So for lung involvement, there is still not an excellent treatment available. We at our center have data with the use of ECP in early diagnosed lung involvement. In that case, patients received ECP together with steroids and had, after 9 months of treatment, 60% had complete responses and another 10 partial responses. And these responses were also durable. So in the case of salvage treatment of steroid refractory chronic GvHD, unfortunately, we do not have a lot of data available for organ-specific manifestations. Hopefully these trials will then start soon within the next time.